since the mid-90s. He's been our speaker selector for the last few years and has done an excellent job helping us out. He's profiled as a holistic biological practitioner, a member of a numerous professional organization. He and Nancy love to travel and lecture together. He attended Lewis University in Illinois and Loyola Dental School University in 79. He graduated. This is in Chicago. Moved to a small town out in Illinois and then got smart and went out to sunny Arizona. Dr. Myers first acquired his first laser in 1999 and since has gone on to lecture for the company in using the Paralaze MVP7 ND YAG for soft tissue laser. He believes the advantages of laser to the practice. He'll show you how to use it practically and how actually to use it to be a product that or a service that not only helps the patient health-wise, but helps the bottom line on keeping these practices open today. It's my pleasure to introduce to you Dr. Nick Myers.
Thank you, Michael. Before I officially begin, I've got a couple housekeeping duties still on my other hat right now. We were, if you don't know, we're recording the whole weekend presentation. The complete selection of DVDs will be available for $250, which is a considerable bargain. You can have these. Take particular lectures, give them to your friends as marketing tools for your colleagues, patient education, staff education, good for team building, things like that. So that's $250, and you can put your orders in with Dawn, I believe. There's a sheet that's been floating around for individual orders. Second thing, directly from Dr. Ewing, we'd like to have everybody, if you would please, deposit a business card on the back table where you signed in for the registration. She would like a nice, clean, legible display of your information so she doesn't have to decipher hieroglyphic handwriting. Also then, lastly, after this presentation, around about 6 o'clock-ish, Millennium Dental Technologies, right next door to the laser manufacturer, is hosting a hospitality suite. I believe it's going to be right in the conference room that's right by the restaurant. So they wanted me to tell everybody that they're invited to come. There'll be some hors d'oeuvres, and refreshments are available. And Mike is quite the, not this Mike, but a different Mike, is quite the connoisseur. So he's got quite a nice selection of beverages, I'm sure, to participate in. And so anything further, there will be ample time for questions after this, the last one of the day. We've had a nice little stretch break now. I'll put my other hat back on now. The purpose of this presentation is really educational on what lasers are, what they aren't, what this one that I use can do, and what it can't do. It's going to start out with a little bit of a discussion on laser physics before we get into clinical applications, because without the clinical applications, you can say, well, what's it going to do for me? Laser physics is important so that you can go out into the marketplace and decide, gee, what is this salesman trying to tell me? What am I actually buying? So that you have some better grounded information on knowing what you'll be better armed for discussions with a laser salesman. So without further ado, I'll see if I can, is this the right way? Yeah. This one? Bottom button? That one, okay. I am in Scottsdale, Arizona, and a member of this organization for, I don't know, the mid-90s. And it's the one organization that I keep coming back to. It's most refreshing, constantly stimulating, and there's always something new. It's not what material is the greatest materials like the HDA had last time, which, depending on who you are, you may or may not be compatible. So this is what we're going to cover: basic science, laser fundamentals, tissue interactions, laser characteristics, some laser safety, infection control, and then clinical applications of lasers. The history of laser history. Laser is an acronym for light amplification by stimulated emission of radiation, which is a mouthful. Einstein was the first modern man that postulated the the effect of that a laser could be done. Basically, he had this notion, and it took almost 50 years before this came. This actually went from the idea stage into something which was tangible and workable. Basically, what you see here is, can you see? When photons hit atoms, they come in and cause the electron to become excited. It jumps up to a higher energetic state, jumps in orbital. It's an unstable phenomenon when it goes from this zero state to an energized state. It comes back, because it's unstable, it's kind of like those Ross free radicals. They're unstabilized and they want to get attached to something. So these electrons are unstable. They fall back into a normal energy state. And it's the falling back from that state to the zero state which causes the the photon to be emitted. Our sun does that. We have sun coming in. Our cells, we become energized, our atoms. The electrons jump up, and when they fall down, we emit photons. Dr. Klinghardt said earlier this morning about cell-to-cell transmission is a photonic phenomenon. So it gives new meaning to the term light beings. We're definitely light beings. We create light internally so that we have this cell-to-cell communication, for one thing. Get the right, there we go. Okay, in stimulated emission, you can have these photons coming in, and you want to, a photon has an excited level. When you get another photon coming in, it causes another excitement of the electron. So then, as they're falling back, you get additional photons coming off. We're going to look a little bit about light, a little bit more. A discussion of waves. This is some basic science, just so we have some good common terminology. In electromagnetic waves, this is a sinusoidal wave. Now, to think of this, everybody's familiar with we're all using cell phones and handhelds now, but a conventional landline telephone with a spiral cord, that's really what you're seeing. An electromagnetic wave is a spiral going through time and space like this, rather than just this sine wave that we see like on an oscilloscope or where we draw on a sheet of paper. The velocity is the direction and the speed. Amplitude is from peak to peak, and wavelength is from peak to peak or trough to trough, however your point of view is. Some terminology. Velocity is 3 times 10 to the 8th meters per second. A wavelength we talked about. It's measured in meters. Hertz is measured in units per second. Wavelength, common wavelength measurements. Microns are 10 to the minus 6. Nanometers, 10 to the minus 9th meters. We're covering this kind of quick because I've got a lot of slides of this basic science nature, and some of it for many of us is going to be repetitious. In the electromagnetic spectrum, we look at this light, the light in the world that we're around in this section, the visible light range. Basically, that's what our eyes perceive. The kind of things that we're working with in our offices, X-rays over here. And if you look at the way the waveform is, very narrow here compared to very wide over here to the right. The further to the right that we go, near infrared, mid infrared, and far infrared. Ultraviolet, if you remember back in the late 70s, we had the ultraviolet curing of composites. The lasers, this is our visible world right here. This little pointer, the laser energy from this pointer, this diode, is around 650 nanometers. So that's within this visible spectrum, but not by much. Dr. Mayman is the first one, Ted Mayman, he took the concept from Einstein and made the world's very first working laser. This is a ruby laser. It's very simple. This is all that it was. This little container here and these pieces. This is a ruby crystal, and this was a flash lamp. And basically, he was just able to take light energy, just white light energy, stimulate the ruby crystal and energize the crystal to create those photons. He was energizing the electrons to a higher level from the ruby crystal and get the coherence, the same wavelength of light coming out. There's a picture of him in 2000, a few years later. I had the pleasure of meeting him just February of this year in Las Vegas. Anyway, now, more to the point, and the context for us as dentists, physicians, and using instruments such as the periolace or the water lace or the biolace. We have an Erconia unit here in the corner on the opposite side. Where do these fall within this electromagnetic spectrum? The helium neon beam, which is what basically this one is, around 632. Some of them are 650. This aluminum gallium arsenide at 820. Often, like this would be the low-level lasers. You hear of soft lasers, the healing lasers that you can use for your face. They're handheld units, cost usually a few $1,000s, up to that one is about $14,000, I believe, with the different attachments. They are down in this area. They're good for musculoskeletal things. They will have some effect on viruses and bacteria. They're anti-inflammatory, antibacterial. As we get further out now, the neodymium YAG laser is its 1064 nanometer. The holmium YAG and erbium YAG, these are the ones, these are your dental lasers right in here. You can see, just so you know, this is where they are. This is the wavelength of these particular lasers. We'll show in a future slide the effect that those lasers will have on different biological tissues. Now, to understand the workings of light, we're going to talk first light about our white light here. The light that's coming out of this bulb and all the bulbs around the room is non-directional. It's scattered. It's defocused. It's just a whole hodgepodge of light. The best term in the context of what we're going to be talking about is incoherent. The difference between the laser, which is coherent, everything is working in the same direction, versus incoherent. Everything's just scattered. It's like Babylon, or the Tower of Babel. Everything is just all in disarray. It's monochromatic. Laser light, like this one here, it's monochromatic. Typically a specific wavelength or length, so you can have more than one coming out the tube at the same time, depending on how it's focused. They're highly focused and directional. This one, for instance, this light I can show, and you all know this. I'm close to it here, and over there on that wall, and over at the back wall, it's got basically the same spot size. So it's highly collimated. All the light beams traveling in the same direction. And everything is in phase with one another, so they're not in competition or causing any incoherency or scatter. I got it that way. Okay, laser light is monochromatic, so all the light is traveling the same wavelength in the same direction. It's collimated. Just like our X-ray units, we have lead blockages on so that we limit the size of the beam that's coming out of the large tube, so we have just a small target area. So too with lasers, we want a collimated beam so that it's able to have just a very small area of working area at the tip end. And it's coherent, which means all the light is going in the same wavelength, in the same phase all the way throughout. What you've been seeing here over to the left of this image is the optical resonator. And we'll show a little bit more detail about that in a little bit. The active medium is what we get the name of the laser from. For instance, it's a gas or a solid suspended in this optical cavity. The neodymium YAG, for instance, is a crystal. It's a piece of crystal that's inside the laser, and it's the light that goes into that. The erbium YAG is a crystal of erbium, and the YAG stands for yttrium aluminum garnet. And so each name has a specific crystal that's associated with it. constant population inversion. This means that an external energy source acts as a pumping mechanism. They take a very bright light, much as this one here is pretty bright light, and it's turned on and off, and that's what they get, this constant stream of the photons, which is energizing the secondary step and making the boil, I think of it as a boil off of the photons from the active medium, which is this solid or gas. For instance, now, active medium, we know of a carbon dioxide laser, for instance. The active medium there is carbon dioxide. It's a gas. The neodymium, the erbium, and the holmium lasers, those are solid crystals. And then the optical resonator are mirrors, which do a little dance. We'll have a picture here. This is the active medium on the inside. On each end, there are these mirrors. One mirror here is fully reflective. So anything that comes in and bounces off of it will go to the opposite side. If you look at the mirror on your right, you'll see it's, compared to this vertical shape, it's horizontal and it's got spaces in between, much like your finger. So the light comes in, and if it goes in between the two black lines, for instance, it'll get lost. It dies at the back end. But if it strikes the end, just like your finger, it bounces back and has another chance to come off. Okay, so it goes back and forth, bounce, bounce, bounce. When you have, and you're boiling off a lot of photons in the reaction, because you've got this external energy source. There's a 110 line, for instance, going into the unit, striking a flash lamp, which is just a real bright light, just like these, striking into this medium, creating these other photons of one type of wavelength and direction. So you have a lot of them going back and forth in the beginning. Some of them will get lost through down here, and ultimately you get, of putting up, let's say 1,000 of these little photons in, you might be only getting out 100, because you're losing so many of them. Now those numbers have no bearing on science. It's just an example. So the photons actually then finally make it out into one small little diameter tightly collimated beam, much like you see on my finger. It's finally coming out. This is the basic principle of all lasers. This is how they all work. The only differences in them are going to be in this solid medium, basically. Is it what crystal or is it what gas is going to give it what characteristics? Some terminology that we have, we talk about energy or joules, the repetition rate or hertz or pulses per second, your power or watts, which is your joule energy over time, the spot size, which is what I'm pointing with, the surface area. And this is determined by their fiber size. There are different fibers that you can buy for the different lasers, and as you start exploring what's on the market, you'll find instead of a fiber, you'll have a glass rod that's not so much a fiber as a tube, much larger, almost the size of the diameter of a half a lead pencil. The light dose is a relatively new term, which is to describe what we're doing clinically in dentistry, so that we have a method of discussing from colleague to colleague how much energy you're actually giving when we're working inside of a periodontal pocket, for instance. On average, 17 joules per millimeter pocket square would be an average for a tooth. Energy density is the amount of energy delivered to the tissue, and that in part is dictated by the size of your spot, how much energy is actually going in at the same time. So these are some of the things that you start thinking of when you're looking to evaluate lasers. Again, joules is a unit of work. So we measure the total joules of a procedure, watts being a unit of power, and the peak power is joules per pulse. And one of the phenomena, I don't know if I'm going to cover that here, is you'll hear the term free running. The Perilace laser here is a free running laser. What that simply means, it's not there's a little gerbil inside there running around on a little wheel. But it's a term that comes out of physics, and the technician is the physicists that do this, is that a free running is that the laser is on for most of the time. It can go on extremely high. So we have a setting, for instance, of 3 watts. Well, when it goes on at 3 watts is the free running average energy. You'll get, for a very brief fraction of a second, 3,000 watts. So you'll get a high peak energy of production, and then it shuts off and you have a long time, relatively speaking, when there's no energy being produced. So that gives a latent period for the cell to recover so that it does not have heat buildup. As heat is an enemy of the tissue, you'll get it like a cooked egg. Some of the devices and operating modes: articulated arm, the hollow waveguide, and the optical fiber. Here's an example of an articulated arm. It's kind of like the old handpieces that we use, the motorized handpieces that had all the pulleys and wheels that could work at various angles, but it was clunky compared to what we see now with our high speeds and our low speeds that have just one very fine air-driven line, for instance, that's coming to it, or an electric line. But it's just a series of mirrors set at 45 degrees to take the beam from the source all the way out to the point of exit. These are very efficient. There's a few of them on the market. The Laris has a new laser on the market, which is the erbium YAG and a ND YAG in the same unit. It looks about as big as a doghouse. So unless you have a supersized operatory, it's kind of hard to get it in there. The hollow waveguide is literally like a garden hose. It's hollow. On the inside, it's coated with a highly reflective surface so that as the photons come down, they can just bounce back and forth and they still come out. And then, now here's spot size or point size becomes important. And then the next one is the optical fiber optic cables that we're using, your telephone lines that are laid between the land, which are now getting obsolete. But if you look at the one next door, you'll see it is very fine. It's about the actual internal diameter of that fiber, the core, is about 3 human hairs thickness. The outside is a little bit larger, and it has a vinyl. It's a vinyl covering. It's a dust cover, and keeps it pretty safe. And then the inside part is this cladding. It's a polyamide coating, which actually is what's coating the light conducting part of the fiber. Continuous wave. Best way I can describe that is if you turn on a garden hose, and I'll use this light, and it's just on. It's just flowing, no stop. It's the same energy from start to finish. And a gated pulse mode, the second one, if you look at the wall here, it's like my fingers are gating it. It's on, off, and whatever the rate is, it's on, off. I can slow it down, or I can speed it up. If I do it fast enough, it almost doesn't even look like anything's happening. In the free running pulse mode, here we go. This is the gated. Free running pulse is that you have, now this is an average time, or excuse me, average power over time. You get these high bursts of peak power, and then it's off, for instance, in this example, 100 microseconds. And then you get another burst of power, and then it's off for another 100 microseconds. So over time, over this 100 microsecond, it's off. It's just dead as a doornail. But when you have these high peak energies, you're getting 2,000 plus watts of energy high up. And so that's where you're getting the work. And then it's off, then it's on, then it's off, then it's on. This is different than a gated, totally conceptually, because that beam stays on all the time. It's just that it's being interfered with. This is physically the beam's going on, the beam's going off. Now this is, from a practical standpoint, it's the same. They're very similar, the gated to the free running, except that the gated has the same energy throughout the whole thing, but we're getting on the free running, you'll find high peak pulse off, high peak pulse. And this is true of some of the other ones, like your water lace and your which is the erbium YAG. laser tissue interactions. The interactions of tissues are dependent on, there are several things that can happen. It can be either reflected, scattered, transmitted, or absorbed. Nothing happens until it's absorbed into the tissue. In this example, you see the source light coming in. Here's tissue here. Light will be reflected. Here is absorbed, transmitted, or scattered. The interaction with the tissue only occurs where it's absorbed. Everything else is basically wasted. Things that are reflected dependent on the tissue type. The laser energy has no effect on the tissue. When it's transmitted, the transmission, it has no effects. Again, energy travels with no effect depending on the tissue type and the wavelength. This is just basically redundant because scattered, it just goes in and it goes around. Now, the thing with scattered, different than the other ones, it could actually further on down, once it's scattered, come into contact with another tissue, then have an interaction with it. This is no different if you took a glass of water, took a flashlight on it, and have it bounce off. That's an effect of scatter. It's finally when it bounces off somewhere else, it'll have an effect because you'll be able to see where that light has bounced off front too. The effect or the interaction is dependent on the wavelength, the composition of the tissue, pigmentation, and water content. We'll see why these are important in just the next little bit. Nothing happens until absorption occurs, and there are these three things recognized of occurring. There's a thermal effect, chemical effect, and then an acoustic effect. This slide is confusing. I don't like this slide. We boiled it down into a chart. Okay. Absorption characteristics of dental lasers. This is the first one. Alexandrite it's not commercially viable and it's not in production in the market. However, it does work on calculus. It's the only thing it works on. An argon laser, and these are the wavelengths here, by the way, and these are the type of active medium. So an argon laser has an affinity for hemoglobin, melanin, and is a resin catalyst. The helium neon 632, which is about what this is, okay, it's a gas, and it has an affinity for melanin. Your diode laser, which there's a lot of them on the market, and they're great for crown troughing, but not a whole lot more. Well, that's unfair. They are used for other things, such as different soft tissue procedures in dentistry. It has an affinity for melanin. The YAG has 1064 nanometer solid melanin dentin. The erbium, the holmium YAG is water and dentin is our target tissues, and water hydroxyapatite for the erbium. So these are these are like your water lace and your biolace lasers, your hard tissue lasers. They act on the water. They cause that water to actually explode, and that's what their cutting action is from. So it's cutting through water. The Nd:YAG is working in a different manner, which we'll see. It's actually having, well, the tissue interaction is here at melanin and in dentin. So there's different effects. For instance, you'll end up, these tips can get quite hot. And we'll go, yes, Kirk?
How they were able to determine the effectiveness of these different wavelengths for different structures. Was it based on the structure's own characteristic frequency, or was it just kind of an experiment that said, you know, we need to change the frequency, no, now it has to do that?
All right. He's asking how it was determined what the wavelengths, what wavelength had what effect on what tissues. And it was just trial and error. They worked on one things, and these were done by physicists in labs and clinicians working and saying, well, let's try this on this, and let's try this on this. And if they saw no reaction, you know, that was no reaction. If they saw a reaction, there was a reaction. That's about all I really know about that. I don't know how that whole genesis of, you know, what kind of slide rule guy in the pocket worked on all these parameters. The photothermal effects. We have coagulation, vaporization, and the photoacoustic effect. Think of this as thunder. There's disruption and there's a plasma effect. The plasma effect is another state of matter. And it's kind of like it's a liquidy electricity is the way I kind of think of it. I don't have a good handle on it for myself because I can't use it in my day-to-day life. Laser-induced fluorescence. Oh, which one did I do here? Mike, help me out here.
Just hit the button. Here, hang on.
That one?
I got it.
Okay. Could you go back? Can we go back one?
Yep. Is that it?
Okay, yeah. Laser-induced fluorescence for caries detection. That's actually, for instance, your Cavo diagnodent. Okay, where the laser, that particular laser energy goes down into the tooth, and depending on the amount of reflectance, there's actually two fibers. One's coming down, that's the energy going out, and then there's one that's right immediately beside it that measures the energy going back into the reader. And it's depending on the amount of bounce back, almost like radar, depending on the amount of bounce back, it detects and measures whether or not it's decalcified. Yeah, I got it now. So with the photochemical effect, it stimulates chemical reactions, it breaks chemical bonds, and then we have a photodynamic therapy. Biostimulation is the next part. Pain relief, wound healing, and collagen growth. These are things that have been studied in many different laboratories around the world, and it's raining a lot. And anyway, the biostim is a wonderful, I don't want to say it's a side benefit, and it's a phenomenal benefit for those that have lasers, and you can use them for pain relief. It's, I know with the NDAG, it's almost instantaneous, the pain relief that you can get in a very short time. On your soft tissue things, on your musculoskeletal things, biostim can take about 10,000 joules, and you can, with a couple treatments, free up frozen shoulders. And notwithstanding the things that we know about TMJ, balancing bites, that all have contributory effects to that effect. The photothermal effect. This is what a clean wound is. Before I'm going to mess up the slide with the description. This is a nice, essentially normal, clean laser cut. What you see here's the parameters that were used. YAG Laser. The pulse width, it's directly proportional to the zone of stasis. I want to spend a little bit of time on this because it's important to understand this slide clinically and why you need to evaluate these various other lasers. We're using these parameters, 100 microseconds and 100 microns. The pulse width, the capillary is 150 microns wide. The pulse width, the closer the pulse width is to the size of the diameter of the capillary, you will get essentially that capillary to be plugged up by a clot, a very small microclot. In the what you're seeing, the term, one of the new term maybe for you with lasers is ablation. Unlike a blade where you're cutting, you're separated into two pieces of tissue, a laser is lifting out. It's like taking that Dorothy's house right out of Kansas and putting it someplace else. It's just lifting it out. Around this zone of ablation, you have these other areas. You have hyperemia and edema. Gets with some minimal cellular injury with marked vasodilatation and inflammatory mediators. This can recover. We're not really trying to coagulate. We want to have stasis. Coagulation is one further step down, which the tissue cannot recover from. In this stage, tissues can easily recover. Stasis is a reversible injury. And for us, that's significant because we're really not creating a coagulation. We see that the blood is stopping. The term, though, is stasis. There's fibrin deposition. There's some vasoconstriction and thrombosis. But this area is still a viably recoverable area that you have. Not right, this very top layer is not recoverable. But the other area underneath is fully recoverable for tissue healing. This is a little more schematic diagram. We cut in the center, we get coagulation, and then stasis and edema. So this is a top-down view, and this would be a side view. So these are the consistent zones that you'll see each time that you use, as you're using this instrument. Tissue interaction, we talked a little bit about this, the power intensity plus the exposure time. So how intense is it? How much time am I giving it? And what is the spot size? Just like we've seen a couple examples today with the projector. We can have a very small spot, or we can get a very large spot, which is what we have here. The power density then, the duration of exposure, the amount of cooling to the tissue, specific wavelength, emission modes, and tissue characteristics give us the biological effect. So that's what we're looking for. What is the biological effect is really what concerns us as clinicians, that we're going to have something that we can use repeatedly and predictably in a cross-section of multitudes of different applications. I've alluded to this several times. In that one slide with the free running pulse, that time when the laser energy is off is referred to as the thermal relaxation time. The tissues are being hit with a lot of energy all at one time. They do get heated, but it's shut down very rapidly, and then it's off. So that's the recovery time is this tissue relaxation, thermal relaxation, or tissue relaxation time. Now, again, with the graphically here, a lower power density because you have a large fiber tip versus it's no different than if you have a lead pencil. One that's been sharpened can go through a piece of paper easy when it's got a very nice sharp point compared to when it's been dulled down. It's got a larger diameter bottom, so it has a lower energy, so it's going to be harder to push through, say, a piece of paper. Thermal effects of laser energies on tissue is what we see here. This is consistent. This is not laser dependent. This is just purely temperature dependent. You see these different areas in degrees centigrade, 37 to 50 degrees C, it's just hyperthermia. Greater than 60 degrees, you have protein starts to denature. You have stasis and coagulation. These are recoverable effects to the tissue. Now we start having negative effects to the tissue when we get higher temperatures, 70 to 90 degrees, the tissue gets welded. 100 to 150 is vaporization, and that's the initial pass. You're cutting, it's vaporizing. And then when it gets too hot, it turns charred. And you can see that. You'll see some slides later what happens when that tissue actually gets really high temperature, turns black. Some of the studies that are out there in soft tissue to validate the use of Nd:YAG. I'm going to close this door. Excuse me. I think he's yelling at me now. It was in Spanish. I needed you to help me. One of the things that it's easy to get confused when you're reading the literature is how much is enough. For instance, there's a laser that's on the market right now, and they tout that it's a 15-watt laser. Well, that's all fine and well, but unless you understand that there's no positive biological effect beyond 6 watts, 15 watts is overkill because you don't need it. They're selling you something you don't need, and if you do use it, you're not going to have a consistent, predictable biological effect with the tissue that you're wanting to have. The cutting dynamics, this is consistent. There's a very small window where the lasers actually work with the power. Tissue removed, this is in distance, micrometers, and with power. The window is a 6 watt, 2 to 6 watts is where all the action is able to occur. Beyond 6 watts, everything is flatlined. So there's no greater effect going beyond 6 watts if you want to go up to 15 watts, which is the most powerful one clinically available today. I had the opportunity to use a 35 watt YAG laser, and we were able to weld 2 pieces of metal together, which is kind of nifty. So it's pretty powerful. Yes, sir. I'm sorry? Yeah, so it's, yes, you're right. It's 1 point, probably 6 or 8. His question was, if I got it right, is there an effect down here? So somewhere around 1.6 or 8 is when the biological effect that you're looking for is taking place. This is an article from 1992, the effects of YAG lasers on curettage of gingival crevicular tissues. This is one of the early studies, unlike some of the biological studies that we've seen going back into the 40s and 30s. This is a recent one. There's 6 subjects, 24 gingival specimens at these parameters, 1.25 to 1.75 watts and 20 hertz. Using a pulsed YAG laser, they were able to use this laser to remove the sulcular lining, the epithelium of a periodontal pocket, without jeopardizing or damaging the adjacent connective tissue. That's pretty phenomenal. For the first time, you're able to get selective removal of diseased tissue. So if you've got a good tissue, healthy tissue on the outside, but just the diseased tissue on the inside, how can you microsurgically remove just the diseased tissue, leaving the other tissue intact? So now for the first time we have a tool, because that's the aim in periodontal treatment, is to remove the diseased tissue. This is some of the histology that was developed by Dr. Ray Yuckna at the University of Louisiana State University, looking at this very phenomenon. What this is trying to show is these are the reedy ridges on the outside part of the tissue, and only the inner part, the diseased epithelium, was removed, just like what you can see in this picture over to the right. This dotted grayish area is what's been removed, leaving the underside intact, and that's what this is here. It's another article done in Germany, clinical evaluation of the effects of a pulsed YAG laser on periodontitis and periodontal pathogens. This was a significant article because what they were looking at, now instead of just tissue, they're looking at bacterial qualities. They're using a 2 watt, 25 hertz, 80 millijoules per pulse, and this is a scaling and root plane control. 10 subjects, 71 teeth here, 38 teeth here. And you have to remember, this is in the early days of what are we going to do with this tool that we have? Is it going to hurt the teeth? Is it going to help us? What's it going to do? One of the questions was answered. There was equal pulp vitality between the root plane teeth and the laser tooth. So that was good because they found there was no damage to the nerve within the tooth, so they could predictably use it without causing the death of the tissue. Equal gingival index. They were seeing nice, healthy looking tissue no matter which technique was used. So they're saying that with that is that from a tissue perspective, there's no difference. Equal pocket depth reduction. Equal P. gingivalis and previtella intermedia. This is at 6 months. So this is just some basic terminology. The YAG laser is able to be used really for all types of periodontal treatment, whatever you feel comfortable with. I only have a couple clinical slides, and then we'll have actually a few x-rays. I have a lot of clinical slides. This is one that's happy to be shown. People always want to know, can this grow bone? Well, this is an example of bone growth using the YAG. This tooth would be considered hopeless by all counts. Anybody here would not feel hesitating to get cold steel and sunshine on that. But as an experiment, it was tried with the YAG laser, and you can see here 9 months later, bone is filling in, and here 14 months, there's you can see the ghost of bone, quite high up on that level now. This bottom aspect is a density, so you're able to see improvement right in these areas. There's virtually no density. These are the teeth here. And then as you go across, the density is improved. So yes, the bone can grow in and can fill when we thought that we weren't able to get any bone whatsoever. This is the clinical case that you'd be happy to see. One of the things here is that sometimes people will say, well, I can do that with root planing and curettage. And that's true. We're going to see these results of this case. This is, you say, a laser or root planing and curettage. Well, this is an immediate post-op appearance with the laser. And this is a week out. Tissue looks great. And then this is several months out, and tissue's rebulbing. But the reason this is a significant case is this woman would not allow conventional treatment to be performed. She didn't want to have anybody monkeying around with her gums, but once she heard about the laser, she was in agreement to allow treatment to occur just because it was a laser. She had heard horror stories, and there are many people in your practices and perhaps friends of yours that have gone through conventional periodontal surgeries and have had a lot of pain. There's a lot, got to wear the packing, they've got to be missing work on heavy pain medication. And you don't have that with these kind of techniques, using lasers for this kind of therapy. We're going to go through some clinical cases, and there's a kind of a potpourri of cases here. There's not just YAG, but there's going to be some CO2 lasers and use cases on this also. We're going to look at fibromas, fibrotic tissue, tissue retraction, aphthous ulcers, frenectomy, soft tissue crown lengthening. There's a relatively large lesion. Here's a fiber, as you can see. This is an YAG, small little fiber. Just able to lift that fibroma right off the tissue. As you notice, there's an absence of bleeding going on. It's because it's sealing as it goes.
You anesthetize the patient. Are you going to submit that for biopsy?
This is, yes, you anesthetize. This is not a no anesthesia technique. And a prudent surgeon would submit that for biopsy. And this is what the wound looks like. Now, a comment about this. The erbium YAGs, or the types, the biolaser and the water lace, can cut soft tissues. There's no doubt about it. They will do that. The thing that they don't do is get this. When they do this surgery, this will be bleeding profusely because there's no way for that to cut it off. I'm sorry? Okay.
He's saying that you can coagulate.
Right. He's saying that it can be coagulated. Some slow the bleeding. I don't have experience with this from when I haven't used it directly. Here's how it looks up about a week later. Fibrotic tissue. A little scratch on the slide. This is very nice just taking off that lump of tissue there so you can access that large lesion on that tooth. Now, should that tooth stay or go? I don't know. These slides look better on the computer program than when they're flashed up here. This is at the end of the procedure and several weeks out. The tissues return to normal. Tissue retraction. This is an YAG laser. Just basically going around and troughing. This can be done with a variety of techniques. A diode laser will also do this. Your water lace can do this. So there's more than one way to skin a cat on doing some of these procedures. This was the uncovery of an implant. It's not recommended to do this. It's a blade would have been better in this particular indication if you're going to be doing implants. Some more crown troughing.
Nick, while you have that slide up, I had a question about what's the effect of laser on the
Amalgam.
next to the amalgam restorations and any other metal restorations like woodwork?
Yeah, it's a good question. He asked if there's any what's the the consequence of using a laser adjacent to an amalgam or a crown or some kind of bridge work. If you're using it if you remember what I said about being scattered or absorbed, if you happen to brush the laser against the metal, it's going to explode, pops. And then you get a little plume of mercury filling material that's going up in smoke. So the moral of the story is, unless you want to do that, don't. Okay? You're using it parallel to the long axis of the tooth in these situations, so you should be away from the amalgam or the margins of your crowns or whatever you're doing, or get the amalgam out of there. Aphthous ulcers. Again, a wide variety of lasers can have a nice effect on treatment of aphthous ulcers. It's claimed anecdotally that once you treat directly an aphthous ulcer or a herpetic lesion, it won't return into the same spot. That just you won't see that. So here's the area immediately afterwards. And this a couple weeks later. Frenectomies. A little orthodontic frenectomy here. Take your fiber up there, open up the tissue, and there it's healed. If I flip past these really quickly, you'll get to see kind of an animation almost. Oops, go back one. So this is what you're seeing. You're seeing the connective tissue fibers through here, these stringy things. And you had a fairly nice, you got certainly a bloodless field, and that will just heal in very beautifully over the next couple weeks. Soft tissue crown lengthening, we've seen some of that already. But here you got some bulbous teeth. There's bulbous tissue over crowns. This is immediate post-op. One of the benefits of using a laser in this kind of application is that you can be very precise. And I like to think of it as what you see is what you get. Because you're able to use such fine, precise motions going around the necks of those teeth, you can predictably carve out what you want to see as essentially the final gingival contours for your tissue and your ultimate restoration tissue interface. So you can do that pretty predictably, right, without having to break stride and just picking up the whatever your laser is, and do that procedure and move ahead with whatever your restoration is. You won't have any wait time for the healing, because that'll heal basically right where it is. There's a frenectomy. Yes. All these procedures are done with anesthesia. Yes. No packing. No tenderness. Oh, maybe an aspirin worth, but as far as no need for narcotics, no Percocets, no Tylenol 3s, or in fact, if you preload them with like an ibuprofen or homeopathic remedies, they don't even need anything. They'll know something was done. It might be a little sore, but most of them don't take anything.
Just one other thing. When you showed that early on about the calculus and this was something in the laser, did you remove that calculus or did you remove it?
No, I said that laser is not commercially.
No, but you showed a slide with some heavy calculus and very bulbous tissue.
Oh, okay, you're right. Yes, the part of the technique that was used for that was to use the laser to open up, excising that inner layer of diseased epithelial tissues, followed up by a hand instrumentation or piezo scalers, eliminating the tartar as far down as you can go on that. And then you come back in with the laser again, making another pass. Different settings, for the hemostasis and final sterilization. One of the benefits, the slide went and I forgot to mention, I'm sorry. One of the benefits of the Nd:YAG wavelength is that you can get approximately 4 millimeter further from the tip. If this is, let's say, if this is the tip of the laser striking the tissue, I'll use my hand this way, you can get the effectiveness of the beam about 4 millimeters beyond the tip. Now, that's significant because the Nd:YAG wavelength has a specificity for things that are black pigmented. One of the more dominant bacteria in periodontal disease are your black pigmented bacteroides. If you're able to ablate them, they just literally explode while they're still housed within the tissues, farther from the tip. So you don't even have to directly touch them in order to have a positive effect of eliminating them from the tissues. And there's a neat card trick that you can do, and I'd encourage you to stop by and have somebody show you. I'd be happy to if I'm there. You can selectively remove black pigmented things through space. For instance, they have a carpule of anesthetic. You can shoot from one side of the carpule and remove the black on the opposite side without having any effect noticeable to you. There's no heat buildup on where the beam is entering, but you can see it just lifting off that top layer of black. It's kind of a neat trick. That answer that question? Part of that technique also, and you saw that in the one radiograph that I had up there, showed that one incisor that had that big halo around it. It was splinted. So that's a crucial part of the technique, is that mobile teeth are splinted to make them solid so that they can heal quietly. You can't expect, if you break an ankle or break an arm, a leg, for it to heal if it's not casted or splinted. It's got to be still. And that's the same basic principles, biological principles that we heard this morning that cause healing to occur or allow healing to occur. There's a few other treatments that can be done. And a perculectomy is one over a cuspid. This was a little aggressive. It was just too much. Because in the next slide you see there's no attached tissue up here. But it worked. The technique worked. It was just a poor result. Periodontal abscess. It's one of the harder things to treat are periodontal abscesses. And this does, YAG Laser does extremely well. You can put your fiber down into the defect and energize. You're killing the bacteria. You're able to get hemostasis, getting a fibrin deposition. And the other thing is, part of it is check the occlusion. You can look at all the trauma that's going on the crown of that tooth. You know that tooth's just getting beat to heck. So you have to relieve the occlusion that's on that, and that will help remedy that periodontal abscess. Here's a post-op picture showing the tightness of the tissue. Some other surgeries. A little papilloma on the palate. Open wide. Lasers are just wonderful tools for these kind of applications, because yes, you numb them up, but there's no morbidity, there's no real discomfort, and the healing of these, and they're very rapid to heal, and people can go back to work right away, or play, or whatever they're doing. And here it's healed up. It's a large.
Question?
Yes, sir.
What's the time frame between your surgery and the healing we're seeing here?
Sometimes just a week. It's very rapid, very rapid. One of the benefits, with all lasers, because you can't see the energy, they're coupled with another beam, such as a helium neon beam, which is an aiming beam. This has a biostimulation effect for healing, so that it keeps the tissues comfortable, or it gives aid to the tissues to be comfortable. Yes, Bill?
Include the periodontal abscess, that deep pocket, or using the ablation in that 1 week check?
I can't. I got this blower right over my head. I can't hear you. I'm sorry.
He asked how long the post-operative films were. You said normally a week. I was wanting you to make exception about the periodontal surgery, about reduction of pocket depth. Wasn't a week, that you check those again.
On the periodontal, on that one slide.
Yeah.
No, typically with before you want to check, really with the way we're looking for that technique, you really don't want to be measuring much before 6 months for periodontal healing, because that attachment is still very immature, and if you put too much pressure on that tissue, you'll just break through that very immature, still healing attachment apparatus. So 6 months, if better, a year out, even up to 18 months out to check for that. There's a large, ugly-looking something or other. I think it could be due to those metals. There's also a partial in there. Now, this was a very aggressive removal of tissue here. I'm not condoning it, but that's just one of the effects. It's somebody who's just taking a little bit too much off in a hurry.
Aggressive removal, is that power settings or time?
Just taking too much.
What does that mean in terms of
So he's asking what is too aggressive? Is it too much power, too much time? It could be, it's just a combination. Any one of the parameters, if you're too much on power, even though you're maybe short on time, you can do damage depending on how much temperature you increase that tissue. Certainly a greater power with a great deal of time, you're going to cook the heck out of the tissue. So that's a really tough question to try and answer, because there's the different variables are still going to cumulatively come to bear on the clinical outcome that we see. And that's part of the art, and that's a touch. And some of the lasers, like a CO2 laser, is a non-contact mode laser. So you're working and you're just watching it occur at a distance from the tip. The YAG laser is occurring, although the action is occurring still further off the tip, there is some tactile feedback that you can have, as well as with the, there's no tactile feedback, for instance, either with the water lace, bio lace, because that's a non-contact mode. You know, one of the reasons a lot of people use microscopy or highly powered loops on for their vision enhancement. This is another case. And yes, they still heal, but they're kind of not so pretty when they do heal. If you go, one of the concepts that has been found out is that if you remove all that flabby tissue, like in traditional periodontal surgery, when you just go in and excise that whole thing, you'll get a huge defect, like what you're seeing here. With a laser, if you can use, it's almost like an arthroscopic incision, or if you're having a gallbladder removed, just a small incision. This is essentially microsurgery. As long as the tissue height is intact, like my arm, if we're not doing this to it, okay, and exposing all that tooth, but leaving it intact and just taking off that diseased epithelial lining, that tissue basically will stay at that height. So you don't have these disfigurements that we commonly have seen in traditional periodontal surgery. Pardon? To a large degree. To a large degree, you can get reattachment. And that's what the name, I haven't talked much about the name, but LANAP stands for Laser-Assisted New Attachment Procedure, because you are able to get new attachment, new physiologic attachment to the tooth root, a cementum-mediated new attachment. So yes, you do get new attachment, and you get new bone growth virtually all the time. Now, you may not get, huge jumps and you'll fill in a vertical defect almost all the way, as long as the scaffolding of bone is there. But if you've got just horizontal bone loss, you may go up a little bit, but you're not going to fill in. Absolutely. Yeah, John. Does the reattachment hinge on scaling and root planing? The reattachment hinges on how well you debride the surface, how clean the surface is of the biofilm, and how many bacteria are you leaving behind, and whether or not you've successfully or adequately stabilized the tooth from trauma so that it's not being hit side to side in its normal occlusion. Well, you're not directly lasing the root surface this way. The direction of the fiber is this way, parallel to the root surface, but just like any beam of light, there is a cone. Okay, so there is some laser energy that's coming out in a cone shape, and it's bathing the side of that root and having an positive effect to the kill of the bacteria. So you're denaturing pathologic proteins like your cytokines, and you're killing the bacteria, which are responsible in part, big part, or at least part of the infective process for having it, the periodontal lesion. I'm sorry, I can't hear. So he's asking if you have to debride the root surface by etching or something. You're debriding the root surface mechanically, and whatever laser energy gets on it, but you're not specifically trying to target the root surface with the laser itself. But there's no other agents that are being used or interposed into the periodontal defect. No. No. Not for this technique. I have in the past, 20 years ago. Yeah, Felix.
For others in the working scatter or striking the root surface of then, do you ever get post-op sensitivity on the hard tooth structure later?
No. The post-op sensitivity is almost non-existent. It's phenomenal. it's one of those things that kind of ceases to amaze you, because you can do this over thousands of teeth and there's virtually no pain. You will get pain if you're setting your parameters are the wrong settings and you're cooking things and that you shouldn't be. Any other questions right now, John?
How fragile is the hardware? And how stable is the calibration? Is there liability for trial?
How stable is the hardware, and is there a liability for harming the patient? Okay. The hardware is quite stable. Solid-state electronics today are not what they were even 10 years ago. So the calibration is consistent. One of the benefits to using lasers, different machines, they've got built-in power meters, so you can check the tip output against what it says you're getting on the control panel. And that's one way that you can verify what you see coming out your tip is actually what you're getting. And there are different, understanding the whole process of laser physics, then if you get a coating of char, and I don't have a cable here, but if you get a char coating because of some carbonization that you may have done inadvertently, your laser output will drop precipitously. It just drops off. And if you don't know that, and you can see you're back in working, and you're not seeing, it says, so I'm supposed to be getting, say, 4 watts of energy, and I'm not seeing any tissue interaction, then I have to start to think something is amiss. So you go back to your power meter and you say, I'm down at 0.5 watts. Because it's just totally blackened the tip, so your energy, your photons just can't come out. So it's heating up the end of that tip. And then you have a different effect. Not what you want. But anyway, as far as, I think that answers your question about that. Now, liability, you're a doctor, you're liable for everything you do. And if you're using it in an appropriate manner, any tool, then the risk that you're accepting by using that, depending on your education and background in understanding that tool, is going to be either high risk to you or low risk to you. It's a nice big old epulus. One of the things that I've really come to appreciate, I did before, but I do even greater now, is the effects of occlusion. We talked about that with Dr. Klinghardt and Dr. Landerman. But one of the problems, if we don't address this, certainly that's a deep bite, this tooth is smacking right into these teeth, causing these teeth to be traumatized. When you have those kind of conditions set up, you can get these lesions become more opportunistic, basically, and you'll pop this kind of thing. The tragedy then comes, in a conventional sense, with these kind of things, is when you just clean them out in conventional periodontal sense, you'll end up having a big disfigurement, such as this. So with the use of a laser, you can go in there. First you adjust that occlusion, make sure that bite is not being traumatic. You can go in there on essentially a low setting and let that body start to heal that lesion up. If there is a problem, you can still go in and excise it with a scalpel, but you're going to have a much less disfiguring lesion response as you do in, say, this kind of response that you see here. Now, to me, that's pretty not so acceptable. Excuse me. This is another one, same type of response from the body. These are, to me, my way of thinking, these are just the body's responses to these traumatic forces that are being put upon it, and foods and whatnot's being irritating to the areas. This is a misapplication of a laser. So was the other one. They just went in and used the laser much like they used a scalpel conceptually. They just whacked the tissue away. Yes, you can use it and you get a bloodless field, but you end up having a very disfigured area. Still didn't fix the bite. Now, this is this particular few slides, large lesion, more appropriately used with a laser. Recognizing that it's a problem, went in and gave it some laser energy, and it just started to heal. Okay, cleaned up the roots with the scaler, and you can see the shrinkage of the lesion. Now watch the next slide. Look how much that has shrunk. Now, if it's chosen now to take that out, you have a much smaller defect than if you would if you just jumped to a conclusion like, oh my gosh, I got to get rid of that thing, and you would have had a huge hole right in a very aesthetically sensitive area. There's a few slides now on leukoplakia, of vestibuloplasty, curing of composite, tooth bleaching. Okay, down in the floor of the mouth, right on the mandible here, at the lesion in here. Mind you, no attempt is made yet to remove any amalgams. Here's a slide immediately post-op. And so 1 week healing.
Is it possible to retrieve the tissue from that case for biopsy?
I'm sorry?
Is it possible to retrieve the tissue in this case for biopsy, or is it required?
In this particular case, no. There was no tissue that was left to, it was just ablated away. It was taken right off the surface. You can selectively, depending on which laser you have, you can start a corner and just lift it up, that layer of tissue, and selectively take off that upper layer so that you have tissue that you can send for biopsy.
Doesn't that expose you to liability if you don't evaluate whether it's dysplasia or in situ or actual frank?
Yes, that's why I say a prudent, whatever a prudent surgeon would do. It's another lesion on the tongue. This was an incomplete removal of the lesion using a CO2 laser, as I left all this here. It healed up nicely where it was removed, but they still left all that other goop. It's a small little lesion here. This would be easily taken off and sent for biopsy. So you can see I'm just showing a number of different clinical applications with a number of different types of lasers that are being used. There's some things that you could do, some things that you don't want to do, but the net effect, my purpose today is to give you an example of what some of the uses of lasers are in dentistry. Here's another one on the side of the tongue. It's a CO2 laser. Looks kind of like a bat, don't you think? This is kind of interesting. One of the phenomenon, and you can take advantage of the heat component of the laser, is that when you can actually melt the layer of dentin, that superficial layer of dentin. When it recoalesces, it's a lot of little balls. So you get all these little ball attachments that are fused onto the surface of the dentin, and then that's where your bonding agent can go in and wrap around. So you cure that, and then you can put your composite down. for a very nice strong bond. The YAG laser is not an effective caries removal agent it's very effective for caries removal, but it's very slow. A much better tool would be an erbium YAG laser for that application. But this is a dry tooth here, YAG laser, no air or water coolant. Let me go back. And you'll just see some charring. You'll see the holes, and then you'll see charring here with a water coolant. Very nice, very defined, small little holes depending on where that laser energy was directed. An erbium YAG with air, water, and coolant, very similar.
How do you judge how close you are to the pump?
On this dead tooth? He's asking how do you judge your proximity to the pulp when you're using a laser. That's clinical judgment. It's you take your available information, the size of the tooth, your x-ray, and you see where you are relative to the tip, for instance. There's a certain depth, just like your burrs, and you can see the tooth structure disappearing before your eyes. And if you're not careful, yes, you can go a little too far with a laser, just like you could do a handpiece. I've gone into pulps before inadvertently, and I'm sure anybody that uses a laser has done that also. Because there's, unlike a burr, though, there's no tactile feedback on the laser. It's because it's off tooth. It's just like, and so you have to watch it. And that's one reason high magnification is important, because you've got, with a water laser, you got a lot of water spray going on, and you can't really see what's going on because of the perception that our eyes have, much below about 3 power. So you need almost 4 power loops or microscopes in order to see what's happening down at the tip, to differentiate between the water spray and what's happening with the tooth, because it's hard to see. And here's an air abrasion. Similar effects. Let's see. Some in vivo rat radiograph and histologic studies. We got different teeth. One of the things that they were looking for in the early times was just some of the questions that you're asking. What is the effect on the pulp from the laser energy? So some of the early literature that had come out was that lasers are bad for teeth, because until you read what the parameters were and understand it in today's context, they were taking the laser, instead of the way we're using it perpendicular to a tooth, they were aiming it right to the tooth and leaving it there for like 5 minutes. And of course, you're going to, with the parameters that they were using, higher powers and long times, they're frying pulps. So that kind of thing early on in the literature cast a pall on what lasers, the benefit of lasers could be for teeth. So it shied a lot of people away from it. This is one slide just showing an exposure that occurred. And one of the nice techniques with these, from a general dental viewpoint, if you get something like this, you can go in and create, oh, heck, darn it. You can create a zone of hemostasis here, put a little flowable composite over the top, Vitromir over the top of that, and then put a restoration on the tooth. You don't have to lose the tooth. You don't have to do a root canal. So it's one of those clinical judgments that you as the clinician now have as another tool, that you don't have to end up sacrificing a tooth. What settings on the periolace? You'd be using your hemostasis. Is it? I'm sorry? Yes. Yeah. occlusal decay using the and detection and removal. This is one of the phenomena that's beneficial for us. Is there's no absorption of the YAG laser in healthy enamel. It's just there's no interaction whatsoever. The free-running pulse YAG has diagnostic capabilities. If there's black on the top of the tooth, and you shine that laser beam onto it, there will be an interaction because it has a high affinity for black. You can see then by cleaning out those grooves just with the laser, because it penetrates several millimeters beyond the tip, very selectively, because the healthy enamel is not involved, you can clean out those deep grooves and see how far down they go. If it's just a groove, now you've proved it. But if it opens up into a deeper hole, then now you have visualization of that. Now, sometimes it's best you have to use the right tool for the job. Although you can use an YAG laser to do a class 1 cavity because of the cleaning up the grooves, it's a slow way to do it. It's not the best way to do it. So you need to be thinking productivity, and you want to just get in whatever is going to get the job done in a good way. So here's an example of that. Taking the laser to the tip of the tooth, or the occlusal of the tooth, into the grooves, and you're just energizing, and you see what happens. Laser tip must contact caries. It has to have access. If your laser doesn't have access to the caries, it won't work, because there's no interaction with the enamel, but it won't be able to allow that energy to go down. So you still have to open that. If you need to, open the top of the tooth up. So the advantages of laser dentistry: it's efficient, depending on the tool, the treatment that you're using. It's precise. As I mentioned, particularly when you're sculpting around gingival margins, for instance. Decreased post-op discomfort. There's hemostasis. Reduced stress for both the patient and the doctor because of the benefits for this. And it's just a wonderful tool. There's limitations, specialized training and safety precautions. There's an initial delay of soft tissue. Clinically, it's not significant, but it does occur. And so if you're wondering, is it a day or two different only from a blade, for instance? There's no comparison, though, with the degree of comfort that the person's going to feel when you're actually using it for them, and they're going to be able to walk back to work on some of these procedures because there's no hurt. The YAG is not for use on bone. The erbium YAGs can be used on bone. You should not use it on amalgam. You can use it, if you use it on amalgam, you do it one time just to know the interaction, but you don't want to typically use it on amalgam. It says it's slower in small letters here, slower than conventional modalities. Maybe yes, maybe no. It just depends. You would not want to use it for a class 1 cavity. It's not good for class 2s. Now, this is not specifically about any laser in general, but you can do class 1s, class 2s, 3s, 4s, 5s with a water laser, the biolaser. They're relatively expensive. We say not because the investment that you have in the laser, yes, they're a pricey item, but it opens up new vistas for you that you're able to do treatment modalities you're otherwise not doing right now. So you're able to keep things in-house. You're able to do a better job often with them in-house than you would if you send things out for traditional surgery, periodontal surgery, or minor oral surgery. So, one of the questions that is often asked is, what do you want, and when you're evaluating, what do you want a laser to do? So somebody could come up to you and say, well, what laser should I buy? And always the response is, well, what do you want it to do? If you want it to do crown preps or fill cavities, the YAG laser is not the laser for you. If you want to do predictable periodontal treatment, then the YAG laser is better than the biolaser. Now, many doctors will have 2 lasers. They'll have one of each because they're specific tools. No different than you wouldn't use an Explorer repeatedly for the work that a periodontal probe would do, but you can, limitedly. You get some idea. And then a second, how much training is required and is it sufficient? The tool is only as good as the training. You know, how many of us have practice management software that have, you know, the manual on it is this thick, and you can do 3 or 4 things in the software. And you say, I know I can do all these other things. I just haven't taken the time and I don't have the inclination to learn all the different components of what's in that practice management software. So if you don't know really how to use the laser to its peak ability, you're going to have less than optimal results with having a laser. It's just the way that part goes. And it's no different than anything at home. If you have a whiz-bang computer that's got 30 programs and you use 2, why do you have it? Additionally, so you evaluate your clinical needs. What are your applications? Again, what are the limitations of the lasers? Is it safe? Is it portable? I mentioned the size of this one laser. It looks like literally like a doghouse. It is so mammoth. But it has 2 nice lasers built side by side to it. Is it is easy to control? How easy are the touch pads on it? Now everything is moving to touch pads and things, so the controls have gotten pretty universally easy to use now. What are the features and accessories? Read bells and whistles. Think of the cost. Is it upgradable? What's the warranty? Your track record, longevity of delivery, quality of construction, how reliable is it, and what kind of service turnaround do you have? So these are just things to keep in mind when you're looking to buy a laser, and hopefully you'll be able to have a happy use of a laser. Yes, John? Oh my goodness. Clinical applications of soft tissue lasers versus radiosurge. I have radiosurge. I've used it for years. There's less pain post-operatively when you're using a laser than with a radiosurge. You can pretty much use the radiosurge for most applications that you would use typically a soft laser for, like a lot of those removals that I showed you, those lesion removals. The one thing that you would not want to do with it is stick an electrosurge probe down into a periodontal pocket, for instance. That would just cook the pocket because the heat buildup is so intense so fast, as opposed to, and it doesn't dissipate after you've energized it that well. So you have, it would eliminate you from being able to use it for the application, at least with this unit over here, is really designed for and best for. Any other questions? Yes, sir. Yes, Pete.
What about the removal of tattoos? Does amalgam tattoos as these dolphins that these girls like to have?
But depending on where the dolphins are, you might want to let them swim. But the amalgam tattoos can be very effectively removed with the laser. Those are painful because you're causing so much explosion of the particles into the tissue. Those will become painful. But it's very effective because it's highly selective to the pigment that's in the tattoo. There's been, that's as far as removal of dolphins, we'll talk about that tonight. Yes, Dietrich?
Nick, could you let us know a little bit what the patient would pay for the different types of things, roughly, sort of rough ideas?
He's asking about what people would pay for different procedures. Certainly that's up to whatever any individual practitioner would want to charge. Regarding periodontal surgery, or the periodontal treatments, like this Periolace has a name for, that would be comparable to what a quadrant of osteosurgery would be in your office. For a lesion removal, I mean, it's, I think, depending on the size of the lesion, it might be $350, $600. It's really kind of variable. As you call up your neighbor and say, hey, what are you charging for this? And you call up the periodontist, what are you charging for this? And kind of get a sense of what it is in your area.
Nick, one other question. How available is this, like, in any particular community? Can we just call any periodontal dentist and ask if you have a YAG laser and assume
Yes.
that you're safe? Or what kind of questions should we ask to be safe with a guy?
Yeah, he's asking what is the availability of the lasers in your communities, and what kind of questions should you ask? Lasers are still pretty new in dentistry. It's probably like where high-speed handpieces were about 40 years ago. They were just starting to come into being, and they had the old belt drives, and so that's, and we're right there today. There's not a lot of, compared to the number of dentists that there are practicing in the States, let alone around the world, there aren't a lot of laser users that one can look to in a community. It's still, from a marketing standpoint, it's a golden opportunity because you can position yourself as somebody that has that technology. What you would call up and ask somebody, do you have an Nd:YAG laser? Or do you have lasers that you use? You know, I have to have this procedure done. Do you have a laser that can do that? And what is your experience in using that for that particular kind of procedure? Do you have any literature? Do you have a website that I can go on and find out about you and your use of a laser, for instance? But they're just not widely available.
Have you seen any training courses specifically with using the lasers that would address the actual science? I mean, I saw a lot of slides that I'm not impressed with the results. It was too aggressive, and I don't want to go through that learning curve with my patients.
Right, and that's why I put down on there. I showed you a whole lot of different types of cases.
I appreciate that.
Yes, and a lot of them were bad cases for shock value because you need to have good training. And that's one of the questions in the evaluation that I put up there is what training are you going to get? Because you want to have, as a practitioner, your ability to go back on a Monday morning and have reasonable confidence that you're not going to harm the patient that John was asking about and what kind of life you'll have and get a predictable result.
And is there a place where you would recommend?
This is each one of the laser types, your Homium, your Nd:YAG, your Erbium YAG, are very specific wavelengths that have their own learning component to them. This was a kind of a smattering overview.
I understand.
Yes. I know. Yes, I'm trying to get to it. So this is what you have, depending on, the first question was, what do you want to use the laser for? Will kind of drive your decision on what laser you want to look at to purchase, and then you contact that company to find out what their particular training programs are. I can speak limitedly about some of the other training programs that they give you a DVD. They'll send you a DVD, and you plug it in, and you have 6 or 8 hours of program learning on how to turn a unit on, what's it supposed to look like, and then they'll often, depending on the company, have a doctor to be able to come into your office and do an over-the-shoulder in your office. And somebody that's already using the laser. The Millennium people, if you want to buy their laser, great, they'll take your money, but they won't ship it until you've had a 3-day training program at their facilities in Cerritos.
I would like to share with everybody that I bought a diode laser.
I have a Clark. He bought a diode laser.
Diode laser training has been abysmal.
Yeah.
And follow-up as well. And it's just sitting there.
Yeah, and that's not for diodes. Sorona has a nice new diode laser, it's $13,000, and there's no training. So it's phenomenal that you can buy a laser, except for this one here, and get away with having zero training on it. And so that's a real key aspect of your looking and evaluating a laser company. Yes, John?
Can you practice on pig jaws?
I'm sorry?
Can you practice on pig jaws?
You could, and depends on what you're doing. I know I was at the laser meeting 2 weeks ago in Tucson, and one of the companies, I think it was Ivoclar, had a pig jaw, so you could slice and dice tissue on a diode laser on a pig jaw.
And about what is the monthly amortization?
I'm really not equipped to answer that. You can talk to Mike Freeman. He may know that. A payment for that laser a month would be about $1,300. One quadrant of osseous fork plus teeth in a quadrant. Is that it? You want to kick me out?
Yes, sir.
All right. Okay, thanks very much. Okay. What's the announcement? All right. 2 announcements. We're going to begin at 8 o'clock tomorrow morning. And then the Millennium Technologies Hospitalities just down the hall here.
Oh, that'd be great.
And that's what, pretty soon? A few minutes? Take your stuff with.
Great, thank you.